Hi, everybody. It's a great honor for me to open this weekly webinar of the International Academy of Clinical Hematology. I apologize for Professor Muhammad Moti, who is the chair of the ICH, that cannot be with us today. I welcome you all wherever you are in the States, Europe, in morning, evening, or night. It's As you know, the ICH has multiple activities, webinars and journal clubs, and for trainees and for pharmacists, for nurses, and many other activities, including meeting. We just came back from Paris for our annual International Academy Clinical Hematology meeting with the 3 tracks, including AML, MDS, lymphoma, and neuroproliferative disorders. And today it's a real honor for me to welcome Dr. Joshua Fein, that is close to my heart, a close colleague of mine, a young colleague, a bright one, that used to work a bit with us, and now he is a clinical fellow at the New York Weill Cornell Medicine, Presbyterian Hospital, and he has a lot of experience in hematology and bone marrow transplantation. He tried to taught me computeral tools and statistical and data mining and computer intelligence, which he's an expert in, and I hardly know the words, but he progressed very fast from there, and he is now involved in research in the microbiome, virome, and other inflammatory stimuli. We had to congratulate him as he received the prestigious American Society for Hematology Research Training Award. So congratulations, Dr.
Thank
Fein.
you.
And he will talk today about very attractive, interesting, and cutting-edge topic, which will be CD47 from bench to bedside. I just want to remind you all that please send your questions, because this is an interactive session, to the chat, in order that Dr. Fein can address them after his talk. So please, Dr. Joshua Fein, the floor is yours.
Thank you so much, Professor Nagler. And I truly must say, when you say you had played some minor role, everyone should know that Professor Nagler was one of the key people in getting me started on this path. So tremendous thanks to you. And it is such a delight to be introduced and to get the chance to chat with you all today. So this talk, CD47 from bench to bedside, I think that question mark really stands out. All of the attention in CD47 has been on some of the struggles and disappointments that the clinical trials, especially the phase 3 clinical trials recently, ran into, leading to certainly magrolimab, the most well-known and furthest along in coming through the pipeline of trials, being discontinued by the company that was leading that effort. And so I hope that over the course of our conversation today, I'll help us decide whether that question mark belongs there. How much attention should we be paying to CD47? But to get there, I think it really merits taking a step back and understanding again what was the biology that led to clinical translation in the first place, and what do we know about that biology now that might change the way we think about this. So no slide deck, as far as I'm concerned, is complete without some help from ChatGPT. So here's our friendly leukemia stem cell being swallowed up by a macrophage. And I have no conflicts of interest to disclose. As I said today, I'll start by reviewing some of the underlying biology, then we'll turn to the bedside and look at the clinical experience with anti-CD47 agents, and then we'll turn back to the bench and look at what's been happening since and what new opportunities may exist. So if we go back to what I would call the prehistory of CD47, before it was even known as CD47, the first time it was described by Poles and colleagues was back in 1986, and they described a antigen that they had found that was highly specific to ovarian tumors. Interesting that they didn't find it in other contexts, or at least not highly expressed anywhere else. And that actually plays out still today. A lot of the trials we see with CD47 were focused on gynecologic malignancies and ovarian tumors because of that high expression. So they named it OA3. Then several years later, there was another group led by Eric Brown at WashU St. Louis. In 1990, they discovered the protein, integrin-associated protein, IAP, and the reason they named it IAP was because of a association. It would bind integrin alpha V beta 3. What's important to note here is that, and also around that same time, it was discovered to be an antigen on red blood cells, which of course is going to be something we're going to come back to a little bit. In 1994, these were all found to be the same. There are several papers that came out around that time that pointed to this same protein showing up in all of these contexts, and they were able to clone it, determine that these were indeed the same protein, and named it CD47. This is, of course, around the time when the clusters of differentiation were getting their names. And I'll point to this figure on the right, which is a cartoon of the actual shape of the protein. You'll see on the N-terminal side, there's an immunoglobulin domain, then 5 transmembrane domains, and then a cytoplasmic C-terminus tail. That immunoglobulin domain is the part that we're going to be particularly interested in today because of its interaction with the SIRP-alpha protein. But outside of phagocytosis, CD47 really does have a number of other roles that it plays. Most of those are through its interactions with integrins, with thrombosbondin 1, and so it's implicated in neutrophil migration and also axon extension. CD47, we often think of in terms of its role with respect to red blood cells. And so that's, I think, the important place for this conversation to start. But to understand that, let's look at what this CD47 and SIRP-alpha interaction looks like. SIRP-alpha is the ligand that's particularly interesting to us. It has 3 immunoglobulin-like domains extracellularly, and when CD47 binds to SIRP-alpha, this leads to the phosphorylation of 2 immunoreceptor tyrosine-based inhibitory motifs, items, on its cytoplasmic end, and that ends up recruiting phosphatases, SHP1 and SHP2. Those interfere with myosin assembly. So that is felt to be the mechanism by which phagocytosis is actually impeded. If the macrophage is unable to assemble myosin properly, it actually can't extrude into the shape that can then go around, whether it's a red blood cell or another cell, and therefore it's disabled. It's not able to do this engulfment and phagocytosis of the presenting cell. So where does this idea that red blood cell clearance, which is one of the key features of the CD47 SIRP-alpha interaction, where does that come from? This goes back to a paper by Oldenborg back in 2000 in Science. They made an interesting observation that red blood cells that were CD47 double negative were actually being cleared very quickly. And so to investigate that, they did a number of experiments, which are depicted here. On the upper left-hand corner, this is actually looking at what happens if you give a CD47 negative, double negative red blood cell to either a CD47 double negative recipient or a CD47 wild type recipient. And the wild type recipient is here in the filled in black dots. And so having that existing CD47 recognition in place is necessary for RBCs to decrease over 24 hours and essentially be fully eliminated. They postulated that it's actually the CD47 that is on the macrophages that are involved in that education process. Then, if these same CD47 negative RBCs are injected into a CD47 negative mouse, as we mentioned, the RBCs were preserved. Here, though, they wanted to look at whether whether there was a lymphoid population that was actually driving this. And so this is a RAG1 double negative mouse, and in the RAG1 double negative setting, the same effect is observed. You still see that if CD47 double negative cells are given to the mouse, they are depleted. So it's not lymphoid dependent. And then on the right, this is a complement, a C3 negative mouse. And again, it's not complement dependent. The same effect is seen. Finally, they then asked the question, is it spleen dependent? So they did a sham surgery. And so these are the mice that did not have a splenectomy versus in the circles here, the mice that did have a splenectomy. And so you can see that only in the mice with a functioning spleen do you actually have this same CD47 dependent effect. If CD47 is not present on the red blood cells, they were removed. Finally, they gave clodronate to these mice to wipe out macrophages. And in the mice that did not have macrophages, the CD47 double negative red blood cells were preserved. In the mice that did have macrophages, the controls here, the CD47 double negative red blood cells, as we've seen over and over again, were depleted. So this led to their understanding that this is a macrophage dependent process, a spleen dependent effect of clearing CD47 positive, CD47 negative rather, RBCs. So putting this together with some subsequent work, this led to the understanding that in red blood cells, CD47 is sort of a clock. And over time, there's loss of CD47. And once there's a depletion of enough of the CD47 on a red blood cell, it is phagocytosed, and that leads to clearing of older red blood cells. Now we're going to move to, I've been joking as I've been talking about this topic lately that I'm basically doing a review of all of the work of the lab of Irving Weissman, but a lot of the slides you're going to see now come from his lab's work, both in the things I'm going to talk about before we talk about the clinical trials and also some of the work afterwards. On the left, what we're talking about here, this is a really interesting study in Cell in 2009. His lab actually published 2 articles in the same edition of Cell, talking about the mechanics and the observations they had about CD47 on hematopoietic stem cells and leukemic stem cells. And the first thing that they establish here on the left is that if a mouse with normal hematopoietic stem cells, this is not a mouse with a leukemia, is mobilized. So in this case, they gave cyclophosphamide and GCSF. Then there is an increase in CD47 expression. This is true both on the GMPs and also on the long-term hematopoietic stem cells. You can see this. This is actually the black line here. This is day 2 after mobilization. So you can see that there's a shift to the right, increasing amount of CD47 expression on the cell. And then as you come back to the gray filled in density, that's day 5 after the mobilization has resolved. And then the light gray represents a steady state that was observed without any of these interventions. So this is true for the GMPs. It's somewhat less true, or at least less of a major effect in the long-term HSCs, but it is still present. Then on the right, they, instead of giving mobilization, used LPS to simulate an inflammatory stress. And so here you can see that same effect take hold. In the black line, this is the increase in CD47 expression on GMPs, increase in CD47 expression on long-term HSCs after 2 days after being exposed to LPS. In the light gray, or dark gray rather, that's getting back to 5 days. The light gray, that is the steady state that they observed absent any of this intervention. And the black is an IAP negative mouse. They then looked at which cells in disease states express CD47. They found that diseased leukemic myeloid blasts actually are representing a significantly higher amount of CD47. So on the left here, this is what they're calling a normal, but they actually point out that these are either CD47 expression on mobilized or cord blood CMPs, GMPs, and myeloid erythroid progenitors and megakaryocyte erythroid progenitors. So you can see as you move into these MPN states, especially CMML, atypical CML, blast crisis CML, and then AML, there's this marked rise in CD47 expression. Now, in the companion paper, the paper that was published in that same edition, they did a very similar, they approached the question very similar, but here they were actually looking at the leukemic stem cells themselves. So in the red, you can see CD47 expression on normal bone marrow hematopoietic stem cells and normal bone marrow myeloid progenitors. And then here in patients, or rather in mice with AML, the leukemic stem cell actually had significantly higher CD47 expression, and this was true even in the bulk cells. They then took this observation and looked at a patient cohort of 132 patients. These were all patients with normal karyotype AML, and they divided them into high and low CD47 expression. This was based on a cutoff that had been previously described in just a gene expression study that had been performed over a decade, or approximately a decade prior. And most of the AMLs actually fell on the low side. But if you look at that CD47 high group, you have significantly worse event-free survival and significantly worse overall survival in the context of this higher CD47 expression. One of the interesting clinical correlates they found is that CD47 high expression went along with FLT3 ITD. However, even when looking only at the subset of patients who had a FLT3 wild type, and again, normal karyotype, they still saw that this relationship was maintained. So CD47 expression is an indicator of a bad actor AML. So then they went to look at this question of phagocytosis. Can they use CD47 blockade to increase phagocytosis of these AML cells? So this was an in vitro experiment, and I'll show you here in green, these are GFP labeled leukemic stem cells, and you can see that the macrophages in the setting of CD47, or anti-CD47 antibody rather, are indeed phagocytosing the leukemic stem cells. And this effect is not observed in controls of an IgG1 isotype or an anti-CD45 anti-leukocyte antibody. On the right, same observation here, quantitative as opposed to a photograph or a micrograph, but I'll point out that they also show in red the normal hematopoietic stem cells, not the LSCs, which are in blue. And so there's actually that ability to differentiate between them, and you're not observing a phagocytosis of all of the healthy HSCs. It's only happening in the LSCs that have exposure to this anti-CD47 macrophage population. One of the rationales for that comes from another paper that was published the following year, where it was observed that these malignant blasts actually express excess calreticulin on the surface. Calreticulin and obviously has a lot of different roles in hematology, and we're used to thinking of it in terms of the mutations that can develop in myeloproliferative neoplasms. But in this context, we should think of it more in its traditional setting as a damage-associated molecular pattern, DAMP. And so the surface expression of calreticulin actually is a danger signal to the immune system. And so what you can see is that in comparing AML cells, ALL cells, CML, and non-Hodgkin's lymphoma to normal peripheral blood and normal bone marrow, the percentage of cells that are calreticulin positive is actually markedly increased in all of the disease states. And that's true, again, when we look at the LSCs, the leukemic stem cells have much higher calreticulin than the normal bone marrow cells. And so the suspicion at that point is that the differentiation we saw previously for phagocytosis is actually because you have this pro-phagocytic calreticulin on the outside of the cell, and you've taken away the blockade, the CD47 dependent blockade. So now let's take that idea. They took this anti-CD47 monoclonal antibody and turned it into a therapy. A number of different companies were exploring how to do that at around the same time. I'm going to speak about a few of them, but mostly about magrolimab, which is the one that has been most talked about and got the furthest along in clinical trials before being discontinued in 2023. So this is from the initial first-in-human study. HU5F9G4 was the initial name, G4 because it had a modified immunoglobulin IgG4 component. And so using this as a monotherapy in solid tumors and lymphomas that were relapsed or refractory, there was a dose escalation phase. The initial question that the investigators wanted to answer is how are we going to avoid that RBC pruning? And so the thinking was we have this sink. The RBCs are actually a sink, and if we can kind of manage that initial pruning of red blood cells, then we reach a steady state. We have young erythrocytes floating around in the bloodstream, and from then on we can keep a maintenance dose going and red blood cells will be maintained, and that is the safe way to approach this. So they started by using a priming and then maintenance phase. And so the priming was a very low dose, ranging from 0.1 to 3 milligrams per kilogram, then maintenance that went up to 20. And eventually there was a loading and maintenance strategy that was adopted that was even higher than that in terms of dosing. So this study had 62 patients with a median age of 60 years. The largest disease group within this study was colorectal cancer, though as we talked about at the beginning, ovarian cancer is known to have a high concentration of CD47, or OAP, as it was found in 1986. OAV rather. And so 13 ovarian cancer patients were enrolled on this study, and there were 2 DLBCL patients on this study. There were no leukemia patients on this study. That was actually a companion study that was started shortly then after. From a safety standpoint, there were a few DLTs, but none of them actually led to a maximum tolerated dose. So the first DLT that was observed was right upper quadrant abdominal pain. It was grade 3 with the 3 milligram priming dose. At that 3 milligram priming dose, there were no further DLTs, and they adopted that. The hemagglutination, which had been a significant concern given the expectation of phagocytosis of red blood cells, was observed. They were actually getting peripheral blood smears after each dosing initially. And so hemagglutination that actually caused a headache, so was considered grade 3, was observed again in the maintenance dose stage, but they didn't have any further events of symptomatic hemagglutination, and so that was considered manageable. And then a maintenance dose was adopted, given that there was no maximum tolerated dose identified. So based on that, as I mentioned, there was a concurrent phase 1 study that was specifically in relapsed and refractory AML. This was the Camellia study. And here there was a phenomenon that was anticipated but was indeed seen of more marked anemia after that initial dose. So you'll see here the gray boxes are the median decrease over 4 hours across each of the doses that the patient received. So they would check the hemoglobin level 4 hours later, and the median of those medians was only about 1 gram per deciliter decrease. However, you can see that there were some drops. These low bars were the absolute maxima in drops, or the deepest depressions that were seen in this change in hemoglobin over 4 hours. So one of them actually got to a drop of over 5 grams per deciliter. And the observation also was that there was no reciprocal reticulocytosis, which we would anticipate. These are marrows that are packed full of AML, and so therefore that interfered with the ability to regenerate these red blood cells. The other observation on this study that was not seen in the solid tumor setting was that all of the patients did experience hemagglutination. There was not an observation of a clinical symptom from that, but it was seen in all of the patients. And as a result of that, there was also a lot of interference with ABO blood typing because of panagglutination. They would get the blood typing back and really not be able to interpret it. And so strategies were developed actually generally based on genotyping the blood and using genotype matched blood in some cases. But based on this experience, it was found that it was safe to proceed in both the solid tumor and DLBCL setting and in the leukemia setting. So the next trial was a study in large B-cell lymphoma, or rather in non-Hodgkin's lymphoma, many of whom were large B-cell lymphoma patients. This was in combination with rituximab, which was felt to amplify the effect. You would get phagocytosis, and then on top of that, the CD20 opsonization from rituximab would lead to an increase, antibody-dependent mechanism for clearance of the lymphoma cells. And this was published in the New England Journal. Advani is the first author back in 2018. And the median age on this study was 59 years old. 95% of the patients who went on this study were refractory to a rituximab-containing regimen. 64% were refractory to their previous regimen. Only 18% had had a prior autologous transplantation. And they found, first of all, that there was a very similar safety profile, that the on-target off-tumor anemia was successfully mitigated in a lymphoma population by the priming dose strategy that they had piloted in the initial phase 1 study. And they were able to achieve a number of partial responses and a small number of complete responses, including 2 DLBCLs. They then moved on to a number of studies in the myeloid disease space, and that's where I'm going to concentrate from here on out. The first of these studies that I'll talk about, which was published last year by Salman, first author, was magrolimab and azacitidine. And this was in higher risk myelodysplastic syndromes. They accrued 95 patients to the study with a median age of 69 years, but a range of 28 to 91. And most of the patients had either high or very high risk by IPSSR, 27% with complex cytogenetics, 22% therapy-related disease, 25-26% TP53 mutated. So again, this is a very adverse characteristic population. And I'll point first to the safety profile, which actually starts to show where we may be headed with this drug. Anemia, grade 3, 47%, thrombocytopenia, 46%, neutropenia, 46%. This is a MDS population. Yes, these are significant, but certainly not out of the realm of what's seen in this population with very severe, with very serious disease characteristics. But febrile neutropenia, 30% or 29%, and of that, there were 11 pneumonia AEs that were grade 3 or greater, including 2 grade 5 pneumonias. There were 7 urinary tract infections that were grade 3 or higher. And there were 6 and 6% infusion reactions that were grade 3 or higher. Other than that, I'll point to GI complaints, which were generally in grade 1 or 2 space, but obviously even grade 1 or 2, those are quality of life limiting. So that included quite a bit of constipation, nausea, diarrhea, and some vomiting. Looking first, though, at the TP53 wild type outcomes, and that's how they broke down the outcomes in this study. There were 61 patients who were TP53 wild type that were evaluable, and what was noteworthy was that all the way out to 17 months of median follow-up, no median overall survival and was reached. There was a median PFS of about 12 months. The complete remission rate that was observed in the TP53 wild type was 31%. And those patients who did achieve complete remission went on to have a 10-month duration median survival. And the patients who then had a TP53 mutation had a 40% CR rate that was observed, only 7-month duration in CR if they achieved a CR. But at 1 year, these patients had 61% overall survival. And so in comparison to the data that had been observed historically with azacitidine as a monotherapy, that was felt to be pretty promising, especially for these TP53 mutant patients, this very adverse characteristic cohort. Also notably, 34 of these 95 patients did go on then to an allogeneic transplant. Alongside this, there was a study in AML. This was 87 patients with a median age of 73 years, ranging from 31 to 89. Again, very adverse cytogenetic risk population, and 83% of these patients were TP53 mutated, partially because eventually the study was modified really to focus on those patients once venetoclax plus azacitidine became the standard of care for AML that was not eligible for intensive chemotherapy. And the rationale there being that AZA plus venetoclax really was not effective in the TP53 setting, and so this would be an area that they could focus on. Again, high rates of hematologic grade 3 events, which are not necessarily surprising, but still noteworthy. But we do have 1 grade 5 febrile neutropenia, 34% with febrile neutropenia, a smaller amount of infusion reactions, but still grade 3 infusion reactions, and 3 grade 5 pneumonias. So this infectious signal certainly appears all the way back in the phase 1 data for this drug. And here we can see this is across all patients. There was a CR rate across all patients of 32%. In the TP53 wild type, that was 33%. In the TP53 mutant, that was 31%. So actually a very similar CR rate. In terms of the MRD negative CRs, it was 16 out of the 28 patients who achieved a CR across all patients were MRD negative, but actually 12 out of 23 TP53 mutant patients achieved an MRD negative CR. And then we can see that you have a median overall survival among these intensive chemotherapy ineligible patients of 11 months. And then in the TP53 mutant group here, a median overall survival of 10 months. This is 72 patients, and that was again felt to be promising given the very poor outcomes that are often observed in this setting. So that led to 3 phase 3 studies. There's the enhanced study, which took the high-risk MDS to magro plus AZA versus placebo plus AZA. Enhanced 2, which took the untreated TP53 mutant AMLs, magro plus AZA versus ven plus AZA. This was eventually shunted to the side in the setting of ven plus AZA not really being a good candidate for TP53 mutant patients. And then enhanced 3, which was the untreated IC-ineligible AMLs, where it was magro AZA-ven versus placebo AZA-ven. And what's really striking here is that all 3 of these studies then were terminated in 2023 for futility. Even with the very intriguing, promising data that we saw in the phase 1s, you can see here the red line is the placebo. They have actually a numerically higher overall survival, a hazard ratio of 1.25 for survival, not statistically significant, but certainly there's not a benefit to the study drug in this case. And there's a numeric increase in the percentage of deaths observed on study. That percentage of neutropenia was similar. Anemia was higher, as we might expect given the mechanism of the drug. Thrombocytopenia was marginally higher, and febrile neutropenia was a little bit higher. Looking then at the enhanced 2 study, again, that same picture of a numeric increase in deaths on the magrolimab arm of the study. Median overall survival was shorter on the magrolimab plus AZA arm, and for that reason, this was considered a futile study. And then here is the enhanced 3 cohort. And again, we see a marked increase in grade 5 events, 18.5 versus 10.9 with placebo. Those are a lot of infections. Grade 5 infections were 12% versus 6%. And as anticipated, much more anemia and doubling of grade 3 or higher infusion reactions. So here you can see again, 36% deaths on study versus 31% with placebo. And the curves certainly don't separate in the direction that we would want them to if we were going to see this move forward. So at that point, these were not brought forward. Since that time, there's been another compound, SL172154. These are data that Amer Zeidan presented at EHA earlier this year. And the idea here was to combine the macrophage target with CD47 inhibition with T cell recruitment, so CD40 antibody, and hopefully then combine the ability to phagocytose and also recruit T cells to use a T cell mediated approach to cell killing these leukemic cells. 39 patients were enrolled on this. Again, it's an older population, as we would expect with AML patients. This is untreated AML and higher risk myelodysplastic syndromes. And 50% of these patients were TP53 mutated, 54% were complex karyotype, and 20% were therapy related. And the high risk MDS group, and in AML, 40% TP53 mutated, and all of those were complex karyotype. And we can see that 60% achieved a CR or modified CR, and in the AML group, 21%, only 3 of those 15 achieved a CR or CRI. There were 2 very high-grade DLTs, grade 4 myocardial infarction, grade 5 cardiac arrest. They are, at this point, described at least as not necessarily study-related, and we will see if there's further movement with this compound. However, given the experience that CD47 blockade has had so far, as of today, September 26, 2024, when we're recording this, clinicaltrials.gov has a pretty limited selection, if you will, of CD47 targeting trials for patients with myeloid malignancies. There are quite a few in solid malignancies, and by quite a few, I mean at least 10 or 15. But in terms of the myeloid malignancies, there are 2 trials with ligufalimab, AK117. There's a trial with HMPL A83, which includes MDS and AML, AUR103 calcium, which is actually an oral CD47 inhibitor, plus AZA, and TQB2928, which is an injected CD47 inhibitor. And what I'll point out here is that all of these, or none of these trials, rather, none of these trials are taking place or enrolling in the United States or in Europe, though it seems like there's still some enthusiasm for this approach in China and India. So we will see whether any of these compounds have interesting clinical data to present. But at this point, it's time to turn back to the bench, because at least with the compounds we've looked at, there doesn't seem to be an avenue forward. So I'll show you some interesting things, though, that are going on in this space. I think one of the really exciting avenues for CD47 is actually in the transplant setting. That may be my bias, since transplant is my clinical interest, but I really think this is where there's some very exciting data, again, coming out of the Weissman lab. So in 2016, Chabra et al. Published an observation that in combination with a c-Kit antibody, an anti-CD47 antibody allows you to actually deplete HSCs in the bone marrow without requiring any chemotherapeutic, without requiring any irradiation. So you can see on the left, this in the black bar is the untreated, the number of long-term HSCs. In gray, this is the anti-CD47 antibody that they included. In red, this is the anti-c-Kit antibody, each by itself. But if they're paired, if you put together CD47 depletion and c-Kit depletion, CD117 depletion, you actually go from a marrow that looks like this with just the c-Kit to a marrow that looks like this. And you can actually deplete the marrow of HSCs. So taking that observation forward, the question became, can we use this clinically in any sort of conditioning approach? And so I find this to be just a really beautiful, interesting study that they did, and I'll tell you why that is. They started with a 4 antibody cocktail that was targeting T cells and K cells with CD122, and then CD47 and c-Kit to eliminate the to condition the bone marrow for first a haploidentical and then a fully mismatched mouse transplant. And they quickly saw that they were getting graft rejection with 4 antibodies. So they added anti-CD4 and anti-CD8 to increase the amount of T cell depletion that was being given. And if we look at the outcomes with this 6 antibody cocktail, you can see that there's a ability then for the donor cells to engraft, and you get a stable mixed chimerism. On the right, you're seeing here a irradiation-based conditioning, and in that setting, you have generally 100% chimerism, but here you're able to achieve a stable mixed chimerism. And with the 4 antibody cocktail, the results are not really differentiable from not receiving any conditioning at all. So then they took this forward and said, well, can we use that stable mixed chimerism to actually allow tolerance of a solid organ allograft? And so here they took heart tissue from the stem cell donor mouse and implanted it into the recipient mouse ear. And so you can see that actually this led to tolerance of the cardiac tissue. And then they took that idea forward, and this is really beautiful. They challenged the mice with various infectious challenges, and this was actually in the control setting. You had a response, but you had a lower response initially after the first challenge in this mixed chimerism setting. But by the second challenge, these patients had a normal immune response. And so you can see that that mixed chimerism was actually stable and maintained a functional immunity. Most recently, Persaud et al. From WashU St. Louis took that idea and said, well, can we get rid of 4 different antibodies to deplete T cells and actually do this with just JAK inhibition, which they had previously observed could be used for T cell depletion. And so they created a conditioning regimen that was based on anti-CD47, anti-c-Kit, and long duration administration of ruxolitinib from day -1 to day +30. And here they saw that they were able to achieve near 100% chimerism in the myeloid cells, and also close to that in the B cells and T cells. So I think this really opens the door to a lot of possibilities, whether it incorporates chemotherapeutics and irradiation in addition to, or eventually is able through some means to completely supplant current modes of conditioning. This could be a much less toxic approach to conditioning. And so these are really exciting observations. Another interesting observation that's come up very recently is that SIRP alpha may actually be an important mediator of secondary HLH. And so this is a study from Kidder et al. In 2020. And here they observed that if they induced an HLH phenotype by giving CPG to these mice, mice that were SIRP alpha knockout would not have the same inflammatory response, would not have the same depletion of multiple hematopoietic cell lines, and also that they didn't observe the hemophagocytosis. So here on the right, they're comparing the SIRP alpha knockout mouse, and in the mouse that did receive CPG, you still see you see that normal phagocytosis, whereas it's not seen in CD47 double knockout. And I think that's the really important point here, is that CD47 double negative is not where this activity takes place. It's dependent on removing SIRP alpha, not dependent on removing CD47. You still see a HLH phenotype in CD47 double negative mice, but you can abrogate that with SIRP alpha knockout. And so can that be then translated clinically? Well, there's a group that's actually trying that. And so there's a phase 1 study that's using an anti-SIRP monoclonal antibody, ELA-026, which is thought to be potentially effective in secondary HLH. And in that setting, they have seen, they've so far dosed the first and second cohort of this group, and seen a percentage of responses. Those responses only occurred in patients who were treatment naive. Patients who had been relapsed or refractory did not respond to this. But I think one of the exciting questions here is whether an approach like this might actually be beneficial when we think about IEC-HS, when we think about the HLH-like phenomenon that we see after immune effector cell administration. And can we build on this sort of a strategy to hopefully diminish that inflammatory cascade in early immune effector cell administration? So with those interesting points on the horizon. I'll summarize that the CD47 SIRP alpha interaction regulates phagocytosis, and so therefore it represents an alternative immune checkpoint. Malignant cells, and that includes leukemic stem cells, have a high CD47 surface expression. That makes this a really appealing target for therapeutics. However, clinical trials of magrolimab, which was an anti-CD47 monoclonal antibody, as well as other compounds that didn't move as far forward, were unable to demonstrate efficacy of this approach. So, and they were really limited by significant, including grade 5 toxicity. A lot of that toxicity was infectious. There are some promising avenues, I personally think, for CD47 as a target in transplant conditioning and other ways that it can be used in the setting of transplant, where perhaps some of these infectious concerns and cytopenias that are potentially associated with CD47 blockade may not pose a huge safety problem because it's going to be in the setting of already completely myeloablating, or at least attempting to completely myeloablate. And then secondary HLH may also partially be driven by disruption of this CD47 SIRP alpha interaction. It's on the SIRP alpha side, not the CD47 side. So with that, I would like to express my deep thanks to many people, but in particular to Justin Kainer on the Weill Cornell faculty, who discussed this CD47 data with me at some length recently, and it was a fascinating discussion that led to some of the ideas that presented here, and also to the American Society of Hematology, which is currently funding me, as Professor Nagler mentioned. So with that, I am delighted to take any questions. I see that there's a couple of questions here in the box. One of which was, how is immune reconstitution affected when using these 4 antibodies, including NK cells? So in the 4 antibody setting, there really wasn't successful engraftment, and so we can't really say. In the 6 antibody setting, the NK cells, I don't believe were specifically that reconstitution was specifically described. It may have been, and I would have to get back to you on that. With respect to why the phase 3 studies failed in spite of the impressive results in earlier studies, I think if we look back at those earlier studies, those safety signals were already there. We saw that there were grade 5 infections. Yes, it's a population that is at risk of grade 5 infections to begin with, but they were certainly prominent adverse events. These were phase 1 studies where we didn't have a comparator arm, and so it's really hard to compare those outcomes. Yes, there were some impressive CR rates, but I think that the safety signals were already present, and that's why we do phase 3 trials. Unfortunately, it didn't pan out, but the underlying biology, on the other hand, I think is really compelling. And so if we can find a way to use this effect, if we can find a way to take advantage of this ability to deplete, in theory, these LSCs, these leukemic stem cells, by phagocytosis, without running into that same set of safety concerns, then that would be a way to move forward. And I think people are working on that, but that's why we're not seeing many trials that are open right now. See another question. Do the murine studies looking at the role of anti-CD47 as conditioning for fully mismatched allo-HSCT look at the rates of GVHD? Yes, actually, that was described in the paper that included the cardiac tissue allograft. They looked at the GVHD scores as they're scored in mice, and none of them reached the level at which the preset threshold for euthanizing the mouse. They actually were quite a bit lower than that level on average. So it certainly raises the possibility that this allows for greater mismatch, but I think that the studies to really understand that at a deeper level have not been done. And then, are there any long-term risks or safety concerns associated with using CD47 inhibitors in patients undergoing stem cell transplantation? That is a great question. And I think we don't know. I think one possibility is that it would depend on the half-life also of the antibody. If that antibody is really having its effect and is out of the system before the graft is administered, that may have a very different phenotype in terms of immune reconstitution than if there's still an anti-CD47 activity at the time of early engraftment. But that's purely speculation. Right, I think that's all of the questions, unless I'm, oh, hold on, I've got another panel of questions. No, I think these are the same questions. How might CD47 inhibitors enhance anti-tumor immunity without affecting normal stem cells or leading to immune-related complications? Yeah, absolutely. I think that's the question that is most intriguing about the biology of CD47 here, which is that it seems like it really needs to be paired with a with that prophagocytic damage associated signal. You get some clearance of normal cells, certainly, and this leaves aside the red blood cells. But in the HSC setting, it's really the leukemic stem cells, which are calreticulin rich in terms of their surface presentation, that are attracting this phagocytosis. And so I think that's the opportunity here with CD47, at least in theory. Whether we can take advantage of that is an important question. Do we have to check for CD47 expression before giving anti-CD47 for treatment, especially in lymphoma? I don't think that question has really been explored, at least not to my knowledge, in detail. So interesting question, and perhaps as these trials, if they move forward in the lymphoma space, as they move forward in the solid tumor space, even if they're not currently enrolling in the leukemia space, we may be able to gather that data and answer that question more conclusively.
So just to congratulate you, Joshua, for a great webinar, very interesting, cutting-edge data. We were all disappointed from the phase 3 studies and extremely surprised and even depressed. But you saw some new avenues in transplant and HLH, which is a terminal disease, very important. And as you say, one of the severe complications of CAR T cells, although low percentage. So congratulations, and we are all looking forward to these new studies with anti-CD47. So thank you.
Thank you.